Okay.
Serena and Alice, it's Motivation Monday. Welcome back to everyone on Facebook. We love doing these episodes. This is really important to us. I'm Alice Crisci, co-founder and CEO of MedAnswers with the FertilityAnswers app. Dr. Serena H. Chen, a fertility specialist in northern New Jersey, serving that whole metropolitan area, helping people conceive who might be struggling with infertility conditions.
Oh my God, did you hear the news today?
What?
A1 3150 passed. So fertility preservation
Woo!
in New Jersey passed the assembly. Now we're just waiting for Governor Murphy to sign.
Okay, great.
So if anybody's in New Jersey, please
Yeah.
send a tweet or email Governor Murphy and tell him that you're in support of access to fertility preservation in New Jersey. This is for people who have trouble with fertility, like cancer patients getting chemotherapy, things like that.
That's incredible news. Serena is a good friend of mine. She is one of the best physician advocates out there. She's always showing up to Capitol Hill every year for Results Advocacy Day. I have also done a lot of lobbying in this space. And the fertility preservation for cancer patients, especially given that my son, who's now 6, only exists. I mean, he truly only exists in the world. Because
where is your miracle baby right now?
I was able to do it. What's that?
Where is Miracle Man? Where is he?
Well, he's so good. He knows when I go live that he's not allowed to walk into the studio. So he's hanging out with his kittens. It's incredible. He's so good about all this stuff. And he's so supportive, you know, of what we're doing at the company, because he really understands that there's so many people out there like me that needs assistance in order to have their dream family. And, you know, the thing about this time of year that I wanted to talk about with you today, Serena, is that people are looking at, okay, what testing do I do and what does it mean as they're heading into next year? They're going through yet another round of holidays where people ask all the wrong things, say all the wrong things. You know, they're dealing with that emotional fallout again. And now they're looking at sometimes some novel testing. Even our genetic panel feels very novel to them, and they want to know, well, what am I really going to get? And here's my concern, is that what we've experienced even with our genetic kit is that people are looking for a magic 8-ball. And they want to know, will this test tell me if I'm fertile or not? And they really just don't understand the complexity of, you really don't, even with all the data in, you still don't know until you go to make an embryo, what the health of the embryo is going to be. And you don't know if implantation is going to happen until you try.
So I think those are really good points to bring up. And one thing that I think is so important for us to know is that even though our testing is not a crystal ball, we have a ton of tech. The testing is not a crystal ball. I do have a crystal ball here.
Is it an 8-ball?
Yeah, but it doesn't work. It's broken. So if I had like somebody who can fix crystal balls, that would be awesome. I've been looking for somebody, but I haven't found anybody. So even though our testing is not a crystal ball, it can say, like, are you high risk for infertility? Are you low risk for infertility? Are you average? So we can give you some general broad strokes about your fertility, definitely. And, you know, we can't do that online. Like, you know, I try to answer questions online, but we can't do that online. So everybody really deserves to see a professional doctor, a physician, and you deserve to feel comfortable, right?
That's right. Because we have so many people.
Even though I don't have a crystal ball, I still feel like people can get really useful advice.
Yeah.
And I also feel like the vast majority of people that I see, because the technology is so good, the vast majority of people I see, we can make a difference. So even though I can't say, okay, you're going to have a baby in December of next year, I do feel like most people, if they get assessed and they go through treatment and they try to get healthy, most people can significantly raise their fertility, if not just end up with a baby. The hard part is that a lot of times we don't know exactly when or how. Is it going to be simple? Like you just need to get a little healthier and we figure out your thyroid and everything's fine? Or are you going to go all the way to IVF? And, you know, sometimes people even need donor egg or donor sperm, but the technology is good. It's just the predictive value is not so good.
Right. And that we have to drive that point home. Any type of fertility testing you do is informative.
Yes.
Not predictive.
Yes. Yes.
That's so mission critical for everybody to really like underscore that, because there just isn't, you can't look and say, well, I have really high AMH. Okay, great. Well, that means you have a lot of follicles. Yeah. That doesn't mean that your egg quality is fantastic. There's not a microscope that we can even look at the egg itself and assess quality the way that there's different assessments of embryo quality. And
so very interesting. I just saw a patient whose GYN, her gynecologist, sent her to me because she was having irregular periods, and the gynecologist was like, oh my God, your AMH is so low and you're young. I'm really worried about you. You need to go freeze your eggs. And we did some testing. We had a very long conversation. And, you know, I talked with her about the fact that AMH, most of the studies are done in IVF patients, and she's not an IVF patient. She hasn't been trying to conceive. So she, but we put everything together, like between her health, her irregular periods, her age, her AMH, her antral follicle count, her FSH, and then on top of it, her family history. Okay. So an immediate relative who was in full menopause by age, like in her 30s. I was like, you know, you have these multiple things going on. It does seem like you're high risk for early menopause, but can I tell you that yes, you're going through menopause at this age? No, I can't say that, but I can say, oh, you have a lot of risk factors, and the risk factors are elevated. And does egg freezing guarantee you a baby? No, it does not. But I know if I freeze eggs now, because you're not ready to get pregnant, these eggs will be better than if you freeze eggs in 2 years or in 4 years. Right. So there's definitely some things we can say.
It's helpful, extremely helpful for decision making. I mean, that's what I'm hearing is that, but you have to have the right person in front of you to help people understand what it all means. So we have a lot of users that reach out to us on Facebook Messenger as their kind of first point of contact with us. And I remember, I mean, so many of them that upload their latest test results and they say, what does this mean? They don't know. And whatever that communication dialogue is with their OBGYN, they don't feel that they've gotten an answer in a way that they can understand.
So do you feel like, I feel like some of our patients that I've seen on the app, they've really been trying hard to get answers from their OBGYN and they're not getting answers. And for those patients, I really feel like that means, you know, like maybe you need a specialist, maybe you need to see another doctor. But other patients I feel like are not going back to their doctor. Like, you know, you get the test result and you had your annual exam, but this is more than just routine care. These are complicated questions, and you deserve a separate appointment with your doctor. You have a concern, you want to talk about it, but your doctor also needs time to talk about it. Don't try to jam it in to your pap smear visit. It doesn't really fit there. Right?
Exactly right. I think that there's that in and of itself, that's so educational, which is to empower people to set separate appointments for separate things. Now it's time consuming. Yes, you might have a copay 2 or 3 times, but in the long run, you have to take it into account all the time savings to get the right answers at the right time.
Well, a huge part of health and wellness is being informed, right, Alice? A lot of it is not necessarily taking drugs or supplements or anything like that. A lot of it is just understanding your health, getting your questions answered, and being informed. That's huge empowerment. With knowledge, you can do so much. And there's only so much you can do with searching on the internet, because at some point, a physician has to kind of lay hands on you and really see you as an individual.
Yes, and get those labs. So let's go through each kind of category of diagnostics. So if somebody is going like, okay, I don't want another year of feeling, the longing. Okay, another holiday season coming with this longing. It's time for me to get to the bottom of this. When it comes to the labs, let's take the woman first and foremost. What are the labs that you want her to get done? You're going to do a blood draw, and what are the hormones that you're looking at?
Okay, so for me, a huge mound of information comes from the intake, talking with the patient. What is your age? What's your height? What's your weight? Have you had any medical conditions? Do you smoke? Do you drink? Are you overweight? Are you underweight? Are you average weight? Do you have a family history of infertility, endometriosis, polycystic ovarian syndrome, premature ovarian failure? Do you have a personal history of like any surgeries or anything like that? So your history is super, super important. And then the tests are day 3 FSH combined with estradiol, progesterone, and LH, because those put you into context. Sometimes if you think you're having your period and it's not really your period, those other labs tell us how accurate that FSH is. I like the AMH a lot because I feel like it tells me above average, average, below average. If something doesn't fit though, AMH can be tricky. And if the blood wasn't handled correctly, or you're on birth control pills or something, it can really throw you off. And by the way, I feel like everybody is on biotin, high doses of biotin, I guess for skin and hair. And biotin can throw your hormone levels off.
I forgot about that. Yeah. Biotin,
so I always forget about that too. And my lab is always reminding me. That's an issue.
Okay. So that's a big deal. So let's underscore that too. So if you're heading in to get an AMH test done, biotin, which is really popular.
Any hormonal testing. Biotin, it kind of wreaks havoc with the tests, apparently. I'm not sure exactly how it does it, but that we have signs up in our labs saying, no, don't take biotin.
For how long though?
We need to know prolactin and TSH levels too.
Prolactin and TSH. Okay, so but how long do people have to abstain from biotin before? Is it a month?
I don't think it's long. I think it's like 24, 48 hours. I don't think it's a long time.
Oh, okay. So,
no, it's not a big washout period.
Yeah, got it. Okay, perfect. So just 24 48 hours. It's not going to ruin your skin or your hair.
Right.
To just stop taking biotin for a bit before you get the day 3. Now, can you explain why day 3 is so magical? Why do we need day 3?
Because the FSH, LH, estrogen, progesterone, the menstrual cycle, they all go like this. So we have a lot of data for when you're on day 2, 3, or 4, but day 3 is ideal of menstrual flow, full menstrual flow. All your levels seem to be down baseline. Like that seems to be the starting point for the cycle. So it gives us, that way we have a lot of data to measure again, so we can kind of see what's going on.
Here's a really important question that takes a lot of people until they're trying to have a baby to even realize, although I feel like pregnancy tracker or period trackers help. What is day 1 truly of your cycle?
Day one, I usually say it's day 1 of full flow. But I tell people, if you can't tell, like if you're just spotting, then then you can come in earlier, because if your levels are off, I can always bring you in later. Whereas if you're too late, then I got to wait for your next cycle. Right. And if you have irregular periods, then if you have irregular periods, you need to see a fertility specialist, because we don't even worry about the testing then. Then we're like, there's a fertility issue.
Right. That's right.
Right, because this thing of wait 6 to 12 months to try to get pregnant does not apply to people with irregular periods.
No.
Yeah. I mean, why do we have to wait?
We don't have to wait. But I mean, why do we have to wait if you know you have PCOS or you know you have endometriosis? At least get in to see a specialty consult to get this evaluation done, so you can be proactive and say, hey, I'm in a high risk category. It's likely that I'm going to struggle. Right. And then that is part of decision making.
And even if you're not going to struggle, it can't hurt to just get assessed.
I think that every single person who's trying to conceive should do a fertility wellness checkup. I want to trademark this or something.
I totally agree.
A fertility wellness checkup should be standard of care.
I agree. And there are a lot of organizations, and even some states like Oregon are very proactive about stuff like that.
Sure.
They're like, everybody should be asked every single year at every primary care visit, are you trying to get pregnant or not? So we can be proactive about contraception, STDs, fertility, all of that stuff. That it's wellness.
You can have the conversation about, obesity and the risk that that poses to, delivery and preeclampsia, all of it. I mean, these conversations have to happen, but if we only have 7 minutes with our OBGYN every year for a quick pap smear and like, hey, a quick check-in, like, oh, okay, you're not trying to conceive this year, great. I'll see you next year, that is not okay. And I get it. There's so many things that are broken on the other side. There's so many things with like how many patients are expected to see in a day, how inefficient the system is run. They get behind because they do have somebody who was proactive and kind of, use the PAP appointment to try to have dialogue, and then they're being respectful. And so then they get behind by an hour and they have people in the waiting room that show up mad, and just have to get back to work.
It's hard on both sides. It's not so patient friendly or provider friendly either. We have a difficult healthcare system, and it definitely requires people to self-advocate and to speak up and communicate and to do a little homework. But if you're on this show right now, this is like you are being really proactive about getting informed. That's a huge part of taking care of your own health. So I want to say congratulations to everybody who's listening now.
Exactly. No, absolutely. Okay, so we've got the labs. All right, so we know that there's day.
Now we want to do the ultrasound. Ovarian ultrasound.
So the ultrasound, what are we looking for?
So I feel like the ultrasound, we're looking for how does the ovary look, what's the volume, what's the antral follicle count. Now I will tell you that this is not a radiology standard. This idea of ovarian volume, how the ovary looks, antral follicle count, PCO appearance or not, are not standard radiologic things. These are things that come out of a fertility ultrasound done by a fertility specialist. We look at ovaries differently, and ultrasound techs and radiologists are not formally trained to do those things. So somebody can go to a radiology center, get a formal ultrasound, and then you come back with a report, and it doesn't really help me because a lot of times they don't care about the antral follicle count. They only care, those guys are looking for, like, is there cancer? Is there not cancer? Is the person pregnant? Are they not pregnant? Are there fibroids or not? They're not looking at your ovarian reserve or thinking about your ovarian reserve. So a lot of times that might need to be done by a fertility specialist or by an OBGYN who understands what you're looking for and does those scans on a regular basis. And some OBGYNs don't ever do a scan in their office, and some OBGYNs do a scan in their office every day. So it depends on the doctor. That's across the board. Every reproductive endocrinologist does hundreds and hundreds of these scans every single week, and we know what we're looking for. But to an
OBGYN who doesn't necessarily.
Right. It's not, and you're not, like, if I send somebody to radiology, I usually people will come in and they'll bring their report and it doesn't really say anything. Now, if you have the actual pictures on a disc, sometimes I can see what's going on, but not always, because they may not take the pictures that really interest me. Like, I always tell people, like, this is, for me, the ultrasound is part of the physical exam. There's no substitute for it. I can't read a report about your exam. I have to lay hands on you.
Right. Now talk about the ovarian reserve, the follicles that you see. How much variability is there in?
Huge variability. It's like, even though I do hundreds of these scans every single week, and I don't know how many thousands and thousands of scans I've done in my lifetime. It's I would say that it's not always easy to see all the antral follicles. It's not easy to count them. It's difficult to standardize it between doctors. But I can tell you, well, your ovaries look average for your age. They look below average for your age, and they look above it. It's similar to the AMH. Yeah, it does a similar type of thing. It's broad strokes. And honestly, I can be wrong. Like I could be like, oh, the antral follicle count looks a little bit low, and then I give the patient medications, and I'm like, oh my God, there's too many eggs. It's so crazy.
Right. So because we have growers, not showers, right?
Yeah.
I mean,
exactly.
There's we see that is that some people you think it's not going to go, and then just a little bit of medication, it's like, I'm awake.
Yeah. So AMH, I feel, is a little bit more consistent if it's done properly by the right lab in the right conditions. It's, for me, a little bit more predictive of above average, average, below average than the ultrasound. Although, because I feel like I'm surprised more often by ultrasound results not correlating with what I see with response. You could get that with everything. Like all of this stuff is just helps you get a gist of the patient. Ultimately, we do not know how you're going to respond until you're actually on the medications.
Right. And again, bottom line, you don't know the quality of your eggs until you go to use them. You don't know.
Now, that's a great question, Alice, because somebody asked me about that today. Like, if I'm 33 and my doctor told me I have the AMH level of a 43-year-old, and you freeze some eggs, are they 43-year-old eggs or are they 33-year-old eggs? And I think most of the data points to them being like 33-year-old eggs. Because we definitely see, like when you look at premature ovarian failure data, people that go through premature ovarian failure at age 39 versus people that go through ovarian failure at 29, we definitely see that the 29-year-olds have higher pregnancy rates. So that kind of means that even though the 29-year-old is running out of eggs and doesn't have very many eggs, they seem like more like 29-year-old eggs.
Right.
Than the ones that older eggs.
It's really about the cohort being premature ovarian failure, not the egg quality.
That's my clinical experience. Honestly, when you look at the studies, it's a little bit controversial. Some people do feel that even when you're young, if you have diminished ovarian reserve, you might have higher risk for miscarriage, which is an older person's risk. Like that the low AMH and the decreased ovarian function is associated with things like chromosomal abnormalities that we see more commonly at an older age, which would mean that you are acting like an older person. But then there's data saying we don't really see that. I don't think we know that for sure. But I would say that I think our clinical experience has been like premature ovarian failure at a younger age does seem to have a better prognosis than at an older age.
Got it. Okay. Well, that's really helpful to know. And if that's potentially because the quality is still intact, that's great. For those who are facing that, because it's a very sad, situation when somebody's 29 and they're facing early menopause.
Yes.
And if they've gone through chemo or if they've gone through another health condition that maybe left them at risk for that, they might understand, but there's just so many people who have no risk factors except maybe family history for premature ovarian failure. And that's just one that's like super devastating, especially for people who go, I spent my whole life preventing pregnancy. Now that I'm ready to do it, I'm told that I have premature ovarian failure.
So frustrating.
And I will say that so many of them question whether or not the hormonal contraception was to blame.
Right. And we know that it's not, because the rate of premature ovarian failure in the population that's never been on pills versus the population that's been on pills forever is the same, and if anything, the birth control pills might delay a diagnosis, but it also does things like protects you from, cancer of the ovaries, cancer of the lining of the uterus, and it also protects your bones, things like that. So I don't think people should beat themselves up over using birth control pills.
Okay, good. All right, I love it. So what's really important heading into this is that there are some at-home diagnostics that you can take advantage of. Consider them. Just consider what Serena is advising, which is that really what you want to do is discuss those results with a specialist. And some specialists will be available via telehealth on the app here soon. So you still can take your results and we have a mechanism we're building so that you can share them with one of our specialists to get true expert input into what it means for you, but that there is no magic 8-ball with all these diagnostics.
And nobody should ever, these things nobody should ever feel like they're pushed to do something they're not comfortable with. So if somebody's telling you, well, this result means you have to do this and you're uncomfortable, that's the time for another opinion.
Exactly. That's time for more than one consult. Yes. So as much as every single person wants a doctor, a professional, or a test to tell them whether they're fertile or not, that's not possible. That's truly
not possible, but you can definitely get a lot of useful information from the testing and talking about it with a professional physician. You have
to have the data. You've got to have the data for decision making. And for many of you who already know you have PCOS or endo, or you have irregular periods or any other condition, including obesity, that does leave people at high risk for infertility, get in to see a specialist right away. Don't wait 6 to 12 months. That is incredibly silly.
So Alice, what's the easiest way to contact the navigator? Is there just a little button on the app?
Well, navigators@medanswers.com. We will build in a little feature so you can just, click a button to get in touch. But navigators@medanswers.com. It's a plural, navigators.
I've been telling everybody to contact you guys, and I realized I didn't know exactly what the best way was to contact people.
Email. We will have a button on the app, but and certainly you can request a telehealth consult, with Dr. Chen in her practice. If you're outside of the New Jersey area, you can certainly do that on a cash basis as well. And you can do that with any number of our experts. Your insurance might cover.
How many experts, Alice? How many experts do you have now, and how many countries?
Over 300, and I don't know my country count right now, but we're on at least let's see, 1, 2, 3 continents. At least 3 continents.
Are you in almost every state?
Oh yes, yeah.
That's awesome. That's amazing.
So
that's the thing is that's the good news is that we can connect you with somebody who is an expert in this area and can give you advice, and anybody who's on this app is somebody really dedicated to people really being empowered with their own information.
That's right. I mean,
we're talkers here.
You guys, they're volunteering their time. This is one of the most important aspects of the platform is that docs like Serena and all these other great experts on our app, they volunteer their time to answer your anonymous questions. And we did just roll out this matching platform. So come on, because we can match you to a solution if you're still trying unassisted, reproduction. We don't like the word natural because there's nothing unnatural about IVF. But unassisted reproduction, you might want to, try a specific ovulation tracker. We can tell you which one is right for you. We can match you to clinical trials, but absolutely we'll match you directly to the right provider as well. So I just want to say thank you so much, Serena. It's always a treat spending my money motivations with you. And we hope you guys find this an empowering conversation that will head into 2020 with, specific areas that you can get answers to, and the specific areas you can't. So we wish you all the best at the end of
happy holidays to everybody. If I don't see you over the holidays, and because Alice and I it's possible we might take a break, but we might not. Maybe we should do I don't know.
We'll wing it.
A pajama session.
We could, a holiday.
Or sweats. Casual conversation in our sweats.
Exactly, with a little spiked eggnog.
There you go.
All right. Well, we love everybody. Thanks so much, and we'll see you next time.
Okay, and remember, if you know how to fix this thing, I got it right here.
Contact Serena. All right. Bye. Bye.